Hi.
How are you? I'm Dr. Elgin. I'm one of the cardiologists. Hey, how are you? A little better than a few hours ago? Yeah. Okay. Well, it looks like the Lasix going in through the IV infusion, so it's kind of continuously going in. It seems like we're getting your kidneys to make a little more urine. That's really what we needed to get done. As long as that keeps progressing, I think we should be fine. Okay. We knew from that right heart cath that we did midweek that your pressures were a little higher than we would like them to be, and the diuresis just wasn't quite enough to catch up to everything that's been going on with you. Okay. I think as long as we're making progress and your breathing's getting better, we're gonna keep this plan going forward. There are other options. I know that the working plan has been for a permanent LVAD. In general, they don't do permanent LVADs in the setting of acute decompensation because those folks don't do well when you put a permanent device in. So we kind of got to bridge her through this in some fashion before we would take that next step for a permanent LVAD type of system. There are some things we can do here that the pumps I can put in that are percutaneous, that are not permanent, that can help support and get us out of a dire situation and really get things stabilized enough that we would proceed with that transplant or the transfer for a more permanent LVAD. There's a lot of things involved in that. I know Dr. Mohan's probably had several conversations with you all about that. Okay.
Not about having that interim step. It's been all about going for the LVAD. We've never heard about anything in between.
Well, because if we can get you to LVAD without having to do those other things, that's kind of great.
Right.
Those other things are temporary stabilizing maneuvers. There are devices that we put in through the groin artery that I can put inside the heart to help. Essentially, it's like a temporary LVAD that we can put in that will take over a lot of the work of the heart, but we can't leave it in for more than probably 3 to 5 days.
Oh, gotcha.
So it will help us bridge through. If we're not getting the response we need with the medications that we're doing, that's a tool that we can use.
So what response are you looking for in order to
her lungs accumulated some fluid. Good question. Her lungs accumulated some fluid overnight, and that's what created the respiratory distress. So really what we're looking for is how much support do we need with the BiPAP, with that machine for the breathing? How much urine is she making to the IV Lasix? And we can turn that infusion up a little bit. We may even, if we needed to, we can add another medicine to try and help her heart squeeze a little harder. So those would be the non-interventional kind of things. If those don't get us moving in the right direction, then we think about doing some of these other invasive procedures. The downside of the invasive procedures, they all go through that leg artery. And so once we put that in, you're really bedbound. And you can't move around as much. So if you need it, you need it. But if we can manage this with medications, at least for where we are right now, that would be our goal. Okay? All right. Hang in there. I know that was a rough night. All right. Well, the good news is when we did that right heart cath midweek, the what we call the cardiac output, so how much blood is moving, was actually pretty good. So I think that tells us that milrinone infusion is also doing its thing. So I think this is just getting that fluid a little more fixed from some of the fluid we needed to give her before because of the ongoing other issues. Okay. All right. We'll keep a close eye on you. Okay. Any other questions I can answer for you?
I don't think so.
I know, it's a lot going on. But we're around, okay?
Okay, thank you.
You're very welcome.